evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at MCure Pharmaceuticals. We at MCure are proud to present Empower Talk, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of diabetes management. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of patients affected by diabetes mellitus. Our distinguished speaker is poised to share his knowledge, insights, and practical wisdom to empower us in the fight against this health challenge. We are thankful to our respected speaker, Dr. K.M. Suryanarayan sir, who has generously decided to share his time and wisdom with us. MCure is privileged to have a role in facilitating this bond. Let me have a privilege of introducing our esteemed speaker for this program, Dr. K.M. Suryanarayan sir is honorary professor at Department of Endocrinology, MS Ramaiah Medical College and Hospital, Bangalore. Sir is recipient of the prestigious Presidential Award Vishesh Seva Medal. Sir is ex-Director General of Medical Services from Indian Navy. Sir is past physician to the President of India. Sir is bestowed with Lifetime Achievement Award by Karnataka Endocrine Society. Sir is past President, Karnataka Endocrine Society. Sir has awarded orations by Endocrine Society of India, KES, and API. Sir has more than 40 publications in national and international journal. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll have expert session on today's topic followed by a question and answer session. I request audience to post their questions in the comment box so that we can take up those questions in the end. Without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of diabetes management. I request our speaker, Dr. K.M. Suryanarayan sir, to deliver his session on role of pioglitazone-based combination therapy in diabetes management in current era. Over to you, sir.
Thank you, Dr. Rishikesh. I'll share my slides. Can you stop sharing, Dr. Rishikesh? Yeah.
Yes, sir. I've stopped sharing.
Yes. Very good evening to all of you. Thank you, Dr. Rishikesh and Dr. Tanmay. And I thank MQ Pharma for giving me an opportunity to speak on this subject on pioglitazone-based combination therapy. I hope my video and audio is clear. Yeah. This is the agenda of my talk. Hiding. I don't know how to. Yeah. 1 minute. I'm trying to take out this, but still hiding the things. Yeah. Okay. What is this? Bokeh has come. Shall I close that? No. Yeah. We know that diabetes all over the world, particularly in Asia and India, the prevalence is increasing. Every time I look at the figures, they look quite old. Because now we thought we have got around 70 crores of diabetic population in India, in adults. But now look at this study published in Lancet recently last year. If you include patients who have diabetes and pre-diabetes, let us say dysglycemia, where the blood glucose is normal, more than normal, as per the prevalence quoted by this India Diabetes Study, published in Lancet, almost 1/5 population of India, 20 to 25%, have got either pre-diabetes or diabetes. So that's a very adults I'm talking. It's a very alarming figure. So most important is there are a lot of patients who are not diagnosed, maybe equal number. And also we have got patients who are pre-diabetes, who are prone to develop increased cardiovascular problems, can progress to diabetes. So that way, because diabetes is a metabolic disorder, can have other risk factors like hypertension, dyslipidemia, obesity, which can all increase the cardiovascular and renal problems, events. So management of diabetes becomes very important. Not only it is just the control of glycemia, to look at in a more holistic way to also control and regulate the risk factors. So what are the unmet needs in type 2 diabetes patients? We know we have understood the pathophysiological mechanism of diabetes in a much better way than what we were earlier. So we had to select drugs which act on different pathophysiological mechanisms. That is the first requirement for a good glycemic control. Glycemic control, today we mean not achieving only the target HbA1c, but also look at the time in range. Means we want in type 2 diabetic patients, more than 70% of the time in a day, the blood glucose between 70 to 180 milligrams. So hypoglycemia is a deterrent in the management of diabetes. So we have to have drugs which reduce the risk of hypoglycemia. We also know that hypoglycemia, particularly in elderly who have underlying cardiovascular disease, can precipitate a cardiovascular event. Most of our diabetic patients are already overweight and obese. And in addition, we should have drugs that would reduce the weight or at least do not increase the weight, in addition to reducing the blood glucose level. And the other most important thing is the compliance and less side effects. The better the compliance, better the control and prevention of long-term complications. So better to use the fixed drug combinations or combination treatment for better compliance. And the aim is not just to control the blood glucose, but also to look at reducing the cardiovascular risk, prevent or at least reduce the progression of the kidney disease and residual risk of cardiovascular disease. So we have got so many things in mind. So to speak, is there any ideal oral anti-diabetic drug? We do not, but still we have got many drugs which you can say which can fulfill these challenges and make the diabetes control better. This is an old slide by DiFranco, what we call the ominous octet. What is this ominous octet? We all of us know that important aspect is there is an insulin secretion which is decreased, what we call the insulinopenia, and then there is decreased progressive loss of the beta cells over a period of time. Along with this, there is an increase in the glucagon secretion from the alpha cells and insulin resistance at all levels, particularly in the muscles, which decreases the glucose uptake. Now we understood there is a defective or deficient incretin mechanism, means when we take food, the hormones which are released from the gut called incretins, as the GLP-1, GIP, the in turn increase insulin secretion and decrease the glucagon secretion. There is a defect in type 2 diabetes, and there is increased lipolysis because of again insulin resistance in adipose tissue and increased hepatic glucose production because of again insulin resistance and more glucose absorption within the kidneys because of the enhanced this glucose transporters called SGLT2 transporters, which qualitatively and quantitatively change in type 2 diabetes. So more glucose is absorbed, the renal threshold increases, and last but not the least, there is a neurotransmitter dysfunction. So we know the level at the kidneys, at the level at the liver, the pancreas, the muscle, adipose tissue, and the brain, and the intestine. So today we have got drugs which can act through different pathophysiological mechanisms, and our idea and aim is to select drugs or combine drugs which act through different pathophysiological mechanisms for better glycemic control with less side effects. Let's look at the diabetes management that's gone through a revolution. We know that ideally, if you asked me about 10 years back, we were more concentrating on the glucose. But we know that it's not just the glycemic control is important. Lifestyle medicine is equally important. Management, diabetes, self-management and education. So we have to individualize the treatment. It is not that across all persons we have to reduce HbA1c to less than 7. We have to look at the other comorbidities in the person, whether he is prone for hypoglycemia, what is his age, what is the lifespan left with him, is he obese, is he lean, all these things into account. But the more important today is looking at whether the person has got an established atherosclerotic cardiovascular disease or he has got indicators of high risk, which means an age more than 55 years with 2 or more additional risk factors like obesity, hypertension, smoking, dyslipidemia are all needed. In that case, the drugs of choice will be an SGLT inhibitors and GLP-1 receptor agonists. If the heart failure is a predominant thing, then SGLT inhibitors become the drug of choice. Not only in diabetic patients, even in patients who have got euglycemia. People with chronic kidney disease with an eGFR less than 60 or with microalbuminuria, the drugs of choice preferred is an SGLT inhibitor or the GLP-1 receptor agonist. In case the HbA1c target is above, we can add GLP receptor agonist to SGLT2 or SGLT2 GLP-1 receptor. All these things are independent of the HbA1c level in a person who is with metformin or even without metformin. That's very important. The other things which we should know is that weight is an important thing. So we have to select drugs which are either very neutral or can reduce the weight, like GLP-1 agonists or SGLT inhibitors or DPP-4 inhibitors. The glimepiride and other sulfonylureas cause weight gain. That's what we have to remember. And also the cost of the treatment and the efficacy. If you look at pioglitazone is one of the efficacious drugs. Here it is said highly efficacious. GLP-1 receptor agonist, metformin, SGLT2, sulfonylureas, and thiazolidine. Out of these, the pioglitazone. Intermediate is a DPP-4 inhibitor. Weight, many of them like SGLT inhibitors and GLP-1 analogs help in reduction of the weight. DPP-4 inhibitors are weight neutral, whereas sulfonylureas and pioglitazone may cause weight gain. This is in a nutshell about the diabetes management, which drugs to choose, and what we have to look at the patient and visualize in each patient the management. Along with this, we have to treat the risk factors like dyslipidemia and hypertension so that we have holistic management. So as I said, combination therapy. Is there any need? I already said diabetes is a complex disease with multiple pathophysiological mechanisms. And the beta cell failure is a progressive thing, and a lot of patients do need insulin at a later date. So, multiplicity of the mechanisms and other hyperglycemia cause for treatment that we have to select drugs which have complementary action to each other. That's very important. Let us look, having understood this, the pioglitazone, what are the advantages? Are there any studies? We all know that pioglitazone is one of the drugs in thiazolidinediones like rosiglitazone. Basically, these drugs are insulin sensitizers. They reduce the insulin resistance at the periphery. The action is through nuclear PPAR gamma receptors. That's what we know. So it can be used as monotherapy or in combination. And a lot of studies to show that it is effective either alone or in combination, and other benefits. What does it do? It increases the insulin secretion. In addition to that, it increases the insulin sensitivity and decreases the insulin resistance. And also it has a lipid-friendly drug. Lipid-friendly means it improves the lipid parameters. And the adverse events are there, which I will discuss in a later, well tolerated otherwise. And it can be used as monotherapy or in combination, maybe early in the disease or even in late. This is Defranzo way back, couple of years back. Because there was a lot of controversy in the use of this drug, some of the countries like France, they almost stopped using this drug because of the fear of bladder cancer. But later on, the meta-analysis has shown that pioglitazone doesn't increase the bladder cancer, as almost similar to other drugs. But earlier that some studies suggested bladder cancer. After that, this was a statement issued by Defranzo et al. Is a potent insulin sensitizers, preserves beta cell function, causes durable, that's very important. The durability is good, reduction of HbA1c, and it is lipid friendly. And not only in blood glucose control, it is also beneficial as far as the non-alcoholic fatty liver disease, NAFLD. More today is a metabolism dysfunction associated steatohepatosis. There are some of the adverse effects like weight gain and increased osteoporosis, particularly in postmenopausal ladies when used for a long time. And it's a quite cost-effective drug. That's what we see. Are there any studies to show its benefit in addition to HbA1c reduction and the blood glucose control? Yes. This one of the studies is PROACTIVE study, which was published long time back, which was done in patients with established cardiovascular disease. And they had the primary and the secondary endpoints. And what they said is 47% of secondary stroke in patients with previous stroke, there is a decrease. That's just for the PROACTIVE study. Subsequently, an article was published in NEJM. The study name, I just don't remember that now. Couple of years back, which showed that pioglitazone in patients of cerebrovascular accidents, even in non-diabetics, decreased the stroke recurrence and events in the future, basically as an insulin sensitizer. That way, it definitely has benefit as well as stroke income. Then this PROACTIVE study showed that 28% decrease in the reinfarction in patients with previous MI, and 37% of the acute coronary syndrome of a previous MI also decreased. And this other studies which have shown that 51% of the mortality decrease in mortality in incident patients on hemodialysis, but mainly the PROACTIVE study which showed that decrease in MI, stroke, and death in patients with chronic kidney disease also. As I said, so it's beneficial as far as the heart is concerned, more lipid friendly, and decreased strokes, and also reduces the incidence of the NAFLD turning into the cirrhosis or even hepatocellular carcinoma. We know that NAFLD or MAFLD is a risk factor for the cardiovascular disease today. It is not just a fatty liver, which we see on ultrasound report, but it adds to increased cardiovascular risk like stroke, like hypertension, like LDL cholesterol, smoking, obesity. So it's an important thing which we have to manage. Let us look at the pioglitazone benefits versus the risk. Definitely, it is a very potent drug. It reduces HbA1c. The chance of hypoglycemia is very less because it is more of an insulin sensitizer and decreases the insulin resistance. So as the blood glucose level comes down, the glucotoxicity decreases. That's how it improves the beta cell function. Not directly, indirectly by bringing down the glucotoxicity. More important, is one of the few anti-diabetic agents which has more lipids benefit. Increases the HDL, decreases the triglyceride, and decreases the blood pressure, maybe to a certain extent, and overall decreases the inflammatory state. More important is the increase in HDL and decrease in LDL. Reduces microalbuminuria, maybe to a certain extent. And as I said, the proactive study has shown as far as the benefit is the heart concern and endothelial dysfunction is improved. And more important is improved in the NAFLD. A lot of trials are there as far as the NAFLD is concerned, where the fatty liver, the hepatocytes which are ballooned with fat, they decrease, and even the improvement in the fibrosis to a certain extent in early stages of fibrosis, F1 and F2 stage. More important adverse effect is the weight gain, which we don't want in many of our patients. But the studies have shown, although the weight gain occurs, it's more of the fat in the periphery, not in the visceral fat. So hepatic and muscle fat content decrease in the visceral and hepatic. So weight gain is an important adverse event. And to a certain extent, because of the vasodilatation, there is fluid accumulation, and a patient who has underlying cardiovascular disease may have a heart failure. Fractures, particularly because it can increase when used in high doses for a long time in postmenopausal ladies, bone fractures. And bladder cancer, I already told, the meta-analysis has shown that there is no increase in a bladder cancer. So there are a lot of benefits as well as HbA1c reduction, blood glucose control, and the cardiovascular and the lipid benefits. New perspective of an overlooked drug. We have been using, in between there was a trend that we were scared when that bladder cancer thing came. Now we have restarted using with appropriate prescription and titration. Pioglitazone remains a useful tool in the arsenal of diabetes management. We have got now the SGLT inhibitors, we have got GLP-1 agonists, DPP-4 inhibitors, sulfonylurea, metformin, even imeglimin, all these drugs, but still pioglitazone has a place in the management of diabetes. Why do we need pioglitazone-based combination therapy? Improve glycemic control, but also improve CV outcomes. That's very important. It's a true insulin sensitizer. Although metformin is also insulin sensitizer, the mechanism was different. So when we combine these two drugs, the additional benefit is there. Insulin sensitizer, decrease the insulin resistance is common, but the mechanism is good. So there is a synergistic effect. As I said, already told about the NAFLD, and as I said, it can be combined with other drugs like metformin and sitagliptin. So there are a lot of benefits, few side effects, and if cautiously and judiciously used in small doses and in combination with other drugs, definitely it can help in the management of diabetes. Some of the side effects could be attenuated by combining with a DPP-4 inhibitor and with a lower dose of pioglitazone. DPP-4 inhibitors have weight neutral effect. They do not cause any hypoglycemia. They increase insulin secretion, decrease the glucagon secretion. Whereas pioglitazone is more of a insulin sensitizer. So a combination of these two drugs can help us. So this I already alluded to. So let us look at the metformin and pioglitazone. As I said, both are insulin sensitizers. Metformin is in addition decreases the appetite, decreases to a certain extent the glucose absorption, and may cause weight reduction in a lot of patients, but most of the time it is weight neutral. But I've seen patients losing weight significantly even with metformin also. It decreases the hepatic glucose output. So the complementary mechanism, the increasing insulin sensitivity, decreasing the hepatic glucose production, decreasing the glucose absorption. When you combine these drugs, effective combination therapy in management of diabetes. Not only improve glucose, but also for reducing metabolic risk, potentially improving major cardiovascular outcomes. So is there any evidence, having looked into the pioglitazone mode of action? Impact of fixed combination of metformin and pioglitazone on insulin resistance of patients with type 2 diabetes. Results of a randomized open study. Look at the insulin sensitive metformin and pioglitazone. This is metformin. This is dapagliflozin. This is baseline. This is after treatment. So after treatment, what he has seen, the insulin sensitivity increases with metformin and pioglitazone combination. Unlike metformin alone or even a dapagliflozin, it has been. Same thing, what we had body weight, you can see here, there is not much of change when you use metformin alone or metformin with pioglitazone. Let us look at the combination therapy of sitagliptin as add-on to metformin versus or pioglitazone. So patients who are already on metformin, if you add sitagliptin and compare with the other arm with the placebo, you can see the HbA1c reduction is quite significant in those patients who added sitagliptin or who are already on metformin treatment and compared to the placebo. Similarly, patients who are on pioglitazone, if you add sitagliptin, there is a further reduction in HbA1c. So this potentiates the action, decreases the HbA1c. Even if patients who are on metformin not well controlled, adding sitagliptin has definite benefits. Same thing, patients on pioglitazone not well controlled, HbA1c is still higher side, can bring it down to the desired level by adding sitagliptin in a dose of 100 milligrams per day. So combination studies definitely help us in the sense 24-week study with metformin and for the study with pioglitazone. I think these are all obscuring, but I have to. Yeah. Sitagliptin added to ongoing metformin and pioglitazone combination therapy in a randomized placebo-controlled 20-week trial in patients with type 2 diabetes. So 13 patients, adults with type 2 diabetes, where mean HbA1c is 8.7%. It's a multinational randomized placebo-controlled double-blind parallel group 26-week trial. Patients randomized to receive sitagliptin or placebo for 20 weeks, 6 weeks. So to look at the HbA1c after 26 weeks of treatment. I think what it comes. What you have seen, addition of sitagliptin 100 milligrams to ongoing combination therapy with patients now are on 2 drugs like metformin and pioglitazone. You added sitagliptin, you find a further reduction in HbA1c to almost here. It has come down from 8.8 to 7.6. Whereas in a placebo arm, there is not significant change. And also 2 hours postprandial glucose, fasting plasma glucose, and other endpoints. So triple therapy here, sitagliptin, metformin, and the pioglitazone combination has helped the HbA1c to the desired level in many of the patients when they could not be controlled with 2 drugs. So this is another study comparing on adding pioglitazone or sitagliptin to patients with type diabetes. Those who are on metformin, you either add sitagliptin or pioglitazone. That's what the study has shown. Type 2 diabetic patients. And mean change in HbA1c, that is what has been looked into. Something else is coming. How did it come? Hope I am audible.
Yes, sir.
Yes.
Am I clear?
Yes, sir.
Dr.
Audible.
Rishikesh?
Yes, sir. Audible.
Because sometimes it comes as your internet is unstable something. Eh? Is it
No,
okay?
you are
I'll continue. So adding pioglitazone or sitagliptin to patients who are already on metformin, sitagliptin and pioglitazone demonstrated similar improvements. So it's almost equal. When you added either sitagliptin or pioglitazone, there was a similar reduction in the HbA1c in those patients who are inadequately controlled on metformin alone. Sitagliptin was more effective than pioglitazone recording lipid and body weight change. Body weight definite, but I don't know about the lipids because sitagliptin is more of weight neutral, pioglitazone may add to the weight. Efficacy and safety of initial combination therapy of sitagliptin and pioglitazone patients with type 2 diabetes. So I put both sitagliptin and pioglitazone from the beginning. What we can see here, there's a definite reduction in the HbA1c even when the study was extended to 54 weeks. So there is a durability. The combination treatment, which you have seen in other sites like Verify trial, where you combine metformin and vildagliptin, there is a durability, much longer time the HbA1c kept under the target. And even the fasting plasma glucose, you can see the reduction here, and that is also not sustained when you compare to sitagliptin pioglitazone combination with pioglitazone alone. So a lot of trials are there when you do the meta-analysis. This is the results have shown 7 RCTs. The studies have included. Combination therapy was associated. The combination of dipeptidyl 4 inhibitors and pioglitazone combination with therapy versus pioglitazone monotherapy in type 2 diabetes. Combination therapy was associated with increased HbA1c reduction and FPG reduction as compared to monotherapy. Combination therapy was not associated with further reduction in higher risk of hypoglycemia, was associated with better improvement in pancreatic beta cell function. That is basically by decreasing the blood glucose level. Fixed dose combination of sitagliptin, metformin, and pioglitazone in type 2 diabetes. So this is the 3 drugs combination in FDC. 236 patients in the age group of 18 to 65 years, HbA1c between 8 and 11. Phase 3 multi-center double-blind study, and what they looked at the HbA1c from baseline to end of the 24 weeks. What you can see here, this is the 3 drug combination, fixed drug, metformin, sitagliptin, and pioglitazone. This is the metformin and the sitagliptin. Definitely you can see the HbA1c reduction is much higher in metformin, sitagliptin, pioglitazone, HbA1c reduction is higher when you compare to metformin and sitagliptin. Similarly, if you look at the The study concluded triple therapy with an FDC of metformin, sitagliptin, and pioglitazone effectively improved glycemic indices demonstrated. So when you have two drugs, the metformin and the sitagliptin, or metformin, sitagliptin, and pioglitazone, the sitagliptin, pioglitazone, metformin combination resulted in better HbA1c control or reduction. I already spoken, these are the different studies to show about the pioglitazone, sitagliptin, and metformin managed treatment either as dual therapy, single therapy, or combination of all the three drugs in the FDC form in type 2 diabetes, showing that they have got a synergist effect and can lead to better reduction in HbA1c and more sustainability. Bladder cancer, that is what lurks in everybody's mind. And there's a article, Global versus Indian Perspective of Pioglitazone-Induced Adverse Reaction, including bladder cancer. This is from the India. Low prevalence of reported overall and bladder cancer specific pioglitazone-related adverse events. This, whatever the analysis shown, Indian diabetic patients who are treated with pioglitazone, the prevalence of bladder cancer was much less when compared to the Caucasian population. We don't know the reason, but the difference in reporting rates could be the genetic makeup, pioglitazone prescription at a lower therapeutic dose, higher frequency of metformin as a concurrent drug, and underreport. So metformin, we know some of the anti-cancer properties. That's what was said in the earlier studies. When used in with pioglitazone, that could be beneficial. But whatever, the studies have shown that there is a lesser incidence and prevalence of bladder cancer in Indian population. The correlation between pioglitazone and bladder cancer is seen with duration of therapy more than 24 months. This is by Mohan et al. And cumulative dose of more than 28,000 milligrams, which corresponds to an average daily dose of pioglitazone about 40 milligrams per day for more than 24 months. Doses used in US and Europe are 30 to 45 milligrams. Normally we use from 7.5 to 15 milligrams. That's what I use. We generally don't use more than 30 milligrams. And to reach this 28,000 milligrams, it would take longer. And if you use low dose, it will take around 10 years to reach this dose, where the chance of bladder cancer is high. Low-dose pioglitazone has to be, of late, become very popular in India due to its efficacy and lower frequency of side effects like weight gain and fatigue. So, to mitigate the side effects, what the recommendation, what has been done practically is to use low dose of pioglitazone in a dose of 7.5 to 15 milligrams. That's what we are seeing today. So, if you use the pioglitazone-based triple combination therapy, that is a DPP-4 inhibitors like sitagliptin and metformin, we know that what we said, the ominous actate, which are the pathophysiological mechanisms it can look into and correct. One is DPP-4 inhibitors increase the insulin secretion, and DPP-4 inhibitors can correct the defective incretin mechanism, and metformin and thiazolidinedione both increase the insulin sensitivity at the periphery, and metformin, thiazolidinedione decrease the glucose output from the liver by increasing the insulin sensitivity and decrease the glucagon secretion, particularly the DPP-4 inhibitor from the beta cells, and increased lipolysis, which occurs, that is decreased by both metformin and thiazolidinedione by again increasing the insulin sensitivity and decreasing insulin resistance. So many of the pathophysiological mechanisms which are involved in the pathogenesis of diabetes, they are looked into by combining these three drugs, that is a metformin, an insulin sensitizer, a DPP-4 inhibitor like sitagliptin, which increases the insulin secretion and decreases the glucagon secretion, and pioglitazone, which is a true insulin sensitizer. alluded to in the last about 30 minutes, the multitude of therapeutic options for type 2 diabetes adds to the complexity of managing patients. Readjust and rebalance treatment over time as physiological changes occur throughout the course of the disease. Diabetes is a progressive disease. There is a progressive loss of beta cells. Our aim is to not only bring down the HbA1c, keep it in range, prevent the long-term complications of diabetes, particularly the cardiovascular and the renal. So early effective treatment, early treatment with better HbA1c control will have the legacy effect. That's what we are seeing by the studies of DCCT trials and the UKPDS trials. So from the day one, it is very important to use maybe one drug or combination of drugs, either separately or in fixed drug combinations, so for effective control of blood glucose and bring down the HbA1c to the target level to prevent the complications. So that we can even postpone the need of insulin for a longer time. So as I said earlier, it has been individualized depending upon the individual patient, whether it has other comorbidities, including the cardiovascular and the renal, whether he is prone for hypoglycemia, what is the age, what is his motivation, what is his family background. All these things have to be looked into when we start treatment for the diabetes. So this combination of pioglitazone, which is an insulin sensitizer, metformin, which is an insulin sensitizer, and also the other benefits which it has, and the sitagliptin, which is a DPP-4 inhibitor, can act through multiple pathophysiological mechanisms of diabetes and can help to reduce the blood glucose, HbA1c, and other pleiotropic like cardiovascular benefits can definitely have. And there is not much of hypoglycemia. So early combination treatment definitely help. As I brought out, pioglitazone can increase the weight, can increase the incidence of heart failure in those patients who have underlying cardiovascular disease, and prolonged high dose use may cause osteoporosis. But small doses can definitely result in control of glycemia without any undesirable side effects. So we have to monitor the weight, we have to look at the heart, particularly when the patient's in pioglitazone. But practically what we have seen when used in small doses, it's a good drug having a lot of benefits, and in combination with other drugs like metformin and sitagliptin, it can add to better management, particularly from the beginning, for a better glycemic control to prevent the complications. I think that is the last slide. Thank you. Back to.
Thank you, sir.
Thank you. Was it audible
for the
clearly?
insightful presentation. It's really, yes, sir. Yes, sir. It was clearly audible and even visible slides. Everything.
Because sometimes it was showing that.
So thank you, sir. So there are a few questions in the chat box. So we'll take up those questions. Yeah, sometimes it shows, but you were audible. There was no lag in the voice and etc. So there is one question, sir. You mentioned about the sitagliptin, pioglitazone, and metformin combination, sita-piomet triple combination. So, in your opinion, what is the ideal patient profile for sita-piomet combination?
What we can see is particularly a young patient who doesn't have any really cardiovascular problem. Means what I mean is doesn't have any heart failure, who doesn't have any akinesia of the ventricular muscle, who is not very obese naturally. We can start from the beginning. The HbA1c is very high, let's say 10 or more than 8.5 or 9. If the HbA1c is very high, say 11 from at the time of the diagnosis, we have to give insulin for a short while, like 4 to 6 weeks, then overlap with oral antidiabetic agents and continue over. So we can start in the early stages of diabetes, start with one drug, then we can start the second drug and then the third drug. And when we can tolerate all these three drugs and effectively control, then we can use a fixed drug combination rather than using it separately. So in the early stages of diabetes, particularly for better glycemic control and with good, this one without any undue hypoglycemia, and for the long-term cardiovascular benefits, which are this lipid profile, lipid friendly and decreasing hepatic glucose output. So these drugs are beneficial. Later also patients who are on other drugs, but they are not effectively controlled. They may be on SGLT2 inhibitors, they may be on sulfonylureas. If they are more prone for hypoglycemia, then naturally we can replace sulfonylureas with pioglitazone. That's an advantage. And start with a small dose, give a small dose like 15 milligrams. Do not start with a big dose, monitor the weight, and that's very important. So at all stages of diabetes, even patients who are on insulin, we can use a small dose of pioglitazone. There, the insulin requirement may come down also. The frequency of injection may also come down. So across all stages of diabetes, patients who do not have any heart failure, patients who do not have fluid overload, or patients who do not have any underlying even other malignancies, we can use it, but we have to select the patient, carefully monitor them and follow them up. And if the weight gain becomes really a problem, then we may have to stop the drug. And patients who are on long-term treatment, we have to monitor their bones for is there any osteoporosis. But I feel in small doses, with other drugs, definitely it is useful in better management of the glycemic parameters.
Okay. Thank you, sir. Next question is again related to the same. In your practice, what is the cutoff HbA1c level where you go for triple combi and where you go for insulin?
The HbA1c is more than 9, say beginning, when you diagnose diabetes, 9 or 9.5. It's better to start 3 drugs. May not be fixed drug combination, start 3 drugs. And as the glycemia improves, as the glucotoxicity comes down, you may not even need 3 drugs, you may need only 2 drugs or 1 drug later on. This is what we see practically. And all the drugs are very effective initially. So when the HbA1c initially is more than 9.5, you start with 3 drugs. Later on, you see how much they require, may have to reduce to 2 or 1. And later on, anybody who is already on 2 drugs, 3 drugs, if they are still not controlled, then you may have to replace with some other drug. Somebody is on sulfonylurea, not well controlled, long-standing diabetes. We have to reduce the dose of sulfonylurea and add a drug like an SGLT2 inhibitor, pioglitazone, or a GLP-1 inhibitor. Okay, what was the second question? Insulin? Insulin, you said something. Insulin, what was the second question, second part of the question? Dr. Rishikesh?
Yes, sir. So you mentioned about insulin resistance.
Your voice is not very clear.
So it is the best test or any clinical way to assess the insulin resistance?
First, we have to insulin resistance. Clinically, we can see when the patient has got
insulin resistance.
Is obese, he's got acanthosis nigricans. Acanthosis nigricans is a very important marker of insulin resistance.
Am I audible?
Grading of acanthosis nigricans, grade 1, grade 2, grade 3, grade 4, we need not go into that. But if somebody has got acanthosis nigricans, which has to be examined at the elbows, at the behind the knees, or even the neck. Neck is the most important. And if you look at that, if that is there, that suggests insulin resistance. Skin tags. There are multiple skin tags. That is again suggestive of an insulin resistance. But objectively, whether there is an insulin resistance to assess, there is no need actually. Most of our type 2 diabetic patients have a combination of both insulin resistance and insulin deficiency. So we have to use drugs which decreases the insulin resistance as well as increase the insulin secretion. Practically doing any test to show that the insulin resistance is there, biochemical test is much not helpful for us to decide the treatment. We can do it. We can do by doing fasting or doing a blood glucose, fasting blood glucose and corresponding the insulin levels, or a postprandial blood glucose and the corresponding the insulin level. But it doesn't practically help us. I think the clinical examination, like obesity, acanthosis nigricans, skin tax, these are more important in knowing that the patient has insulin resistance. And the fasting blood glucose is very high. That itself is a sign of insulin resistance, particularly in the early stages of diabetes, because it is insulin resistance at the liver level which causes increased neoglucogenesis and more fasting blood glucose. So these are the markers of insulin resistance, and we have to see that reduction of the weight decreases the insulin resistance. That's a very important thing. In addition, exercise is one way to reduce the insulin resistance. Daily physical activity. The third is the drugs like pioglitazone and metformin can reduce the insulin. But any drug, like whether it is sulfonylurea or insulin, can bring down the blood glucose level. When the blood glucose level comes down, it decreases the leukotoxicity and the lipotoxicity, and the insulin sensitivity automatically improves at the muscle level, at the fat level, and at the pancreas, beta cell level. So that is what we have to look.
Thank you, sir, for the detailed and elaborative answer. Next question is, would pioglitazone-based therapy be preferred in patients with T2DM and NAFLD?
Yes, this is one of the good drugs. NAFLD, we know today as such, we don't have any approved drugs. Pioglitazone has been tried and it was recommended as one of the important drugs. But only the disadvantage which was found is a lot of our patients of NAFLD or diabetes, they are already obese. That's one of the things. Obesity itself is a risk factor for NAFLD, and diabetes is a risk factor. Pioglitazone, definitely in small doses, helps in NAFLD, and along with lifestyle measures, along with drugs like metformin or SGLT2 inhibitors or a GLP-1 analog, definitely is useful in NAFLD. It can be used. And today it is one of the important thing which we have to look, NAFLD, which we are not taking so much importance earlier. And there are a lot of trials with SGLT2 inhibitors, GLP-1 agonists, and what we call the thyromimetics. One of the thyromimetic drug has been approved by the FDA for NAFLD, and pioglitazone has been there for a long time. Drugs like vitamin E and so many other things have been tried, but pioglitazone is definitely helpful and we can use it, but watch out the weight, use in small doses. In addition to pioglitazone, make the person to lose weight, exercise, regular physical activity definitely will help you.
And sir, last question. There are other triple drug combinations available. So again, what will be the difference in the patient profile compared to sitapiomate? See, what will be patient profile for sitadapamate and sitaglimamet?
I couldn't get you. Can you repeat?
So there are other triple drug combinations also available besides sitapiomate. There is sitadapamate.
Yeah.
And sitaglimamet.
Yeah, today India.
So what is the patient profile for those triple combinations?
India, what practically I advise all of our colleagues is preferably don't use any fixed drug combination from the beginning. This is a practical way of looking at it. So like the first drug of choice in most of our patients is metformin. And many of our patients do respond to sulfonylureas in the beginning. And today now we know that SGLT2 inhibitors have more than one benefit of lowering the HbA1c. They are cardiovascular friendly, they reduce the heart failure. They also benefit as far as the kidney is concerned. So Oglibos has a better effect on mostly reducing the postprandial blood sugar. Pioglitazone again is an insulin sensitizer. It can reduce the blood glucose well. So we've got different drugs. So what my suggestion is, we have started the drugs individually. Then somebody is on SGLT inhibitors, you try to give a combination of SGLT inhibitor with metformin, maybe with sitagliptin. Somebody is on pioglitazone, metformin, and sitagliptin, then you give a combination of that drug. So you give individually, separately these drugs. And if a person actually has a underlying heart failure, SGLT inhibitors combination is a better treatment. That's what we look. If somebody has got a problem, GLP-1 analogs, particularly the weight is more, GLP-1 analogs are the better drugs of choice. Although the GLP-1 agonists, we do not have any fixed drug combination or any combination treatment. Somebody has got a postprandial blood glucose very high always, but the fasting is okay and you are not able to control and the patient is not willing, the drugs with voglibose combination is better. Patient who is more prone for this hypoglycemia, you give a combination of gliptins which do not cause any hypoglycemia. So you have to see the patient individually, looking at what combination suits them. Ideally, start them separately. Look at the adverse events. When there are not much of side effects and the patient can tolerate, change over to that combination, whether it is sulfonylurea, metformin with voglibose, or a DPP-4 inhibitor and the SGLT inhibitors with metformin, or a sitagliptin pioglitazone metformin combinations. Today we have got even the SGLT inhibitors plus sulfonylurea combination. Somehow I am not very enthusiastic about sulfonylureas with SGLT inhibitors combination. I not really using those drugs. But these drugs combination can be used in any patient depending upon the background of the patient, his glycemic parameters, whether he is obese or lean, whether his cardiovascular problem is there, whether he is prone for hypoglycemia, what is the age group, how much you need to reduce the HbA1c. Start individually and then use the fixed drug combination over a period of time and continue and reassess. That's what I feel is the best. Yeah, Rishikesh.
Thank you, sir, for clearing the doubts and individual patient profile you have mentioned. So I think we are done with the questions from the chat box. So we are nearly at the finish line. But before we can program possible, I extend my deepest answer for his insightful presentation pertaining to diabetes management using pioglitazone based combination. I would also like to thank for making this program a resounding success. On behalf of MCure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at MCure who have contributed to this program's success. Let's carry this knowledge into our practices, research, and advocacy, fostering healthier future for patients with diabetes. Thank you once again for attending and encouraging us. Good night and good time ahead. Thank you.
Bye. Thank you and good night to everybody. Bye. Rishikesh
Thank
and
you, sir.
Dr. Tanmay.
Thank you,
Thank
sir.
you.
Thank
Bye.
you for your time.
Thank you, sir.
I have to stop sharing. No? Where is it?
Yeah.
Something is like this. Leave. Leave, is it? Leave.